morning, Dr. Patino here at the Cosmetic Surgical Center of Aspirated. We're going to do micro air power assisted. What does that mean? Look at the power. I turn the electricity on, and it's like it vibrates. The tip vibrates. It's like an electric toothbrush, right? So when you do this, and the way we do it is, I am not using this instrument as an old toothbrush without electricity, right? The idea is that you go slowly and you let the instrument do its work. If I'm hammering at it, back and forth at full speed, guess what? You're gonna have gum bleeding, like when the toothbrush, right? So you got a brand new electric toothbrush, but you're using it like an old brush, so there is gonna be bleeding. The same principle applies here. If I'm hammering this instrument with full force back and forth, there is going to be bleeding. But do you see bleeding right now? What do you see?
Yellow fat.
I want to hear from you.
No bleeding.
I know. What color is that fat, you guys?
Yellow.
This is gold.
Gold.
Yes,
and
it
yellow.
is gold here at the Cosmetic Surgical Center of Aspirated. And this is the first time you see this?
No, not here.
We do it consistently and predictably, but it is a technique that is definitely unique. It's a very unique technique, but it takes many things. Probably one of the most important things is the strokes of the surgeon, how slow I am. And notice, this is my non-dominant hand, right?
Wow.
So this has many advantages for the patient. Okay, number one, so less risk of bleeding, meaning less risk of anemia, less risk of hematoma, less risk of reoperation because of bleeding, less risk of that post-operative exhaustion. The patient is so tired because they lost so much blood, they cannot even move. And also, less risk of pain because this numbing medicine that we put here stays in the system for 2 days, which are usually the most painful periods, right? That's why our patients are almost jumping and dancing and going up and down stairs and on the very next day, and the people cannot believe it. But this is what the reality is. And when you do this in a completely bloodless manner, also for the liposuction part, there is much less risk of that octopus effect, which means that there is a central hematoma, a central collection of blood, and then on the tunnels of liposuction, fibrotic bands, those famous fibrotic bands that form, and sometimes they're painful. It's like chords of a guitar, they describe it, the patients. We never had that, never. And the reason why is because there is no bleeding. So my dear friend, Dr. Guillermo Lugerman, postulated the octopus effect, meaning that it looks like an octopus with a central hematoma, and then the tentacles, if you would, right, of the octopus are the lines of the liposuction. But it doesn't happen here. It's never happened, and I don't think it will ever happen, let's hope, because of our technique that is completely bloodless. It's also oil-less, meaning that we do not transfer blood, we don't transfer oil into the butt, so as a result there is less risk of oil cysts, which we never had, and also blowout fractures. Alright, so there is also much less risk of intrathoracic, this is the thorax right here, or intra-abdominal, the belly's over here, organ injury, right? Something we never had, right? And why? Well, because I think that when a surgeon perforates an internal organ, it is usually on a Friday night after doing many cases. There is some surgeons that do up to 10 cases or 13 cases per day of a fat transfer to the buttocks, for example. I only do 1 or 2 at the very most, usually just 1, right? And so I'm not tired, right? So this is also good for the surgeon because the surgeon is fresh, It's a full night's sleep. I'm not operating on many patients. I'm not in any rush whatsoever. Look how comfortable I am. I'm using both hands, so you saw me use my non-dominant hand before, and I use my dominant hand now. And what that means is also less risk of injury to the surgeon, right? The repetitive injury, the repetitive motion can cause injury, right? In the form of tendinitis at the elbow, tendinitis at the shoulder, tendinitis on the wrist area. And so if you do this all the time, and by doing it with both arms, with both hands, then you have much less risk of that. You basically decrease your risk by 50%. But more importantly, you decrease the risk on the actual patient, right? So the patient will have much less risk of you going into an unintended area, right? I see this as driving, right? So I compare this to, driving a car on a freeway, right? Me, I'm really comfortable. I have a full night's sleep. I'm not like tired from driving all over the country, right? So I'm just, going to one city at a time, right? And basically, I'm not driving at full speed, right? So what happens is that the surgeon that is tired already from driving all night, basically, goes at full speed, and when you go at full speed, you can go to an unintended area when you're tired, right? That's what happens. You lose control of the vehicle, you lose situational awareness, and there you go, you crash, right? And, I see that probably most surgeons drive around 75 miles an hour, and that's pretty safe, but you see some surgeons driving at 260 miles an hour on the freeway, right? And that's dangerous. I think it's I think it's ultimately putting this profit over your patient's safety, honestly. And so it's, to me also, it's like when you're driving in the freeway and you see that guy that zooms right by you, right? It's also inefficient because then you exit the freeway and you see them waiting on a red traffic light. I'm thinking, what was all that rush about, right? And the same thing can apply here in surgery. It's very, very similar. It's not a perfect analogy, but I think it's very similar, So, because when you speed, there is more risk. And so when you go at this at full speed, you can injure something inside the thoracic cavity. Notice how I'm doing my non-dominant hand again, and look how my strokes are so slow. This is compared to driving 45 miles an hour on the freeway, right? And the reason why we do this slowly is not to damage the fat cells also. It's not just for bleeding, but we purposefully put the aspirator pressure very low, less than 18 millimeters of mercury when we aspirate. Because if you go at very high pressures, you can destroy the fat cells. And so when we do this, our fat graft retention, this is going to be the very same fat that's going to go into her buttocks. You'll see it. It's incredible. So when we put it in, focus, and if you see, this is what comes out, and this is exactly what's going to go in. So even though we go slow, we save a lot of time because we don't have to process this fat in any way. So when all this is blood, red, and full of oil, you have to process the fat, and that takes time. It may take half an hour, maybe even an hour. That's time that we save because we don't process the fat at all. The fat that you see coming out is the very same. So now she's on the other side. Buttocks are over here. We call it the lateral decubitus position, and that's something that our South American colleagues like to do, and I've been doing it forever, over 20 years doing this position, and I love it. So I think it's much better than just doing prone and supine. In other words, just with the face down and with the face up. It's better to do it on the side. We do all positions, but I think there is some angles here that are better. But what I was saying is that look at that pure, beautiful, bloodless and oil-less fat. That's the fat graft that's gonna go into the buttocks, right? And like I said, we don't process this fat in any way other than we collect it in normal saline, that's all. But this is just unbelievable. And so the time that you save by not processing the fat is incredible. So our times, even though I go a lot slower, are way more efficient, right? Because we don't have to process that fat that's all bloody and all full of oil, right? And as a result also, because our fat graft is so 100% pretty much fat, it's not oil, it's not blood mixed in there, because it is all fat. And because, very importantly, the fat graft is being collected in a low pressure and without damaging the fat cells, but by forceful, aggressive liposuction with aggressive big cannulas, then the fat cells survive. So we don't. So yeah, so it's a delicate manner of treating the fat graft, because the fat cells are very delicate and they can just die easily. And then of course you hear that, you know, with this procedure, fat transfer to the buttock, you lose about 30 to even 50% of the fat that you put in the buttock. So the first couple weeks it looks great because the tissue is swollen and everything, and as the fat cells die and as the blood gets reabsorbed, then you end up with much less. See, with us, you get to keep all that. We don't give you like a mega butt. We just do whatever is proportionate and good for you. And of course, if you want a mega butt, then we can do it, but we would have to do it in several sessions, not all at once, because the subcutaneous space only tolerates a certain amount of fat, right? And then once the fat starts coming out and the tissues are becoming tense, then you gotta stop, right? So those are stop points for us, right? But the bottom line is that when you collect the fat in a gentle manner, like I have shown you, right? Very, very gentle with very low pressures on the aspirator. Of course, that's gonna take longer time, you know, but it's gonna preserve your fat cell, and it's gonna have all the benefits that we talked about. Because I believe that the blowout fractures happen because there is a foreign body reaction from the oil and the blood that doesn't belong there. The oil, you know, belongs inside the fat cell, and the blood belongs inside the blood vessels, right? But when it's outside, where it's supposed to be, then the body rejects that blood, rejects that oil, and it creates a capsule around it, and it pushes it out to the superficial layer, you know. And in addition to that, when the surgeon destroys that superficial barrier, the superficial gluteal fascia, then, and especially when the surgeon massages or does aggressive transferring of the fat, especially under high pressure. So some doctors also inject the fat at high pressure. We inject at very, very low pressure, less than 13. So that, all that is a combination of things that allows us for a much better fat graft survival. In other words, the fat that we put in there not only is pure fat without oil or blood, but also it's gonna survive because it is not damaged with aggressive liposuction. That's the key. And look how beautiful she is. I'm gonna go ahead and define these high definition to the paravertebral muscles on this side as well. We haven't done it, but we'll do it later. Thank you. So I'm now doing high definition on the back side, right? This is her back, the spinal cord is here, and this is the paravertebral muscle. You see I'm making that line, and I have it on the other side as well. And I'll make it better later on, but I'm just giving you an idea of how it's gonna look. Thank you. So she's on the other side, on the lateral decubitus. That means she's on her side. The buttocks are over here. Make sure we don't show the buttocks. Look at the waist. Look at the beautiful waist, you guys. And this is again the pinch test on this side. It's at 0.5 centimeters. This is just like incredible everywhere you go, you guys. This is the way it is, you see? Incredible here at the Cosmetic Surgical Center of Cerrito. She's down to her bones! And we're gonna turn her face down now. We call that the prone position. We're gonna do her buttocks. Thank you. Wow, so notice how, look at this, the line we made here, and look at these lines here on the side, the paravertebral muscles right here. So this is high definition on the back side. Look at that. Look at how beautiful that is. You see those lines here? You see this line here, and this line here, and this line here?
Yeah.
Yeah, it's incredible. And the buttocks are over here. Thank you.
Ultrasound guided gluteal fat transfer, and it's a good thing too today because there's such a small space for a doctor to be putting the fat. So this is the patient's skin. This right here is the superficial gluteal fascia, and then right underneath is the deep gluteal fascia, and this is all the striated muscle. So this is Dr. Patino's cannula, and you'll see as he kind of withdraws that there's really not a lot of space in this deep subcutaneous space for him to be putting the fat. So
how much is, that is the tiniest thing we've seen.
Yeah.
How much is in there?
Oh, it's like 1/3 of a centimeter or something. It's really
wow,
small.
it is crazy. You can see how accurate you have to be, and it's impossible, I would say, to do it without ultrasound guidance and go in the deep subcutaneous space where you should be. So I'm wiggling the cannula, and you're gonna see I'm wiggling it right there, and show him again the tiny space that we have to be so precise.
So again, this is the cannula, this is the deep, this is the superficial gluteal fascia, and then right underneath we have the deep gluteal fascia, and so it's really, really tiny in this patient.
Okay, so let's go and let's see. As I inject, you're gonna see a cloud, a gray cloud. That's the fat going in. 1, 2, 3, go.
Alright, so see how that gray cloud is coming into the space, and all of a sudden everything is getting pushed. We see the superficial gluteal fascia getting pushed up a bit, and then as the fat enters the space, we're going to see that the deep gluteal fascia gets pushed down as it occupies this space.
Look how space got bigger all of a sudden.
Yeah.
With all that cloud of fat.
That's amazing.
Wow, thank you.
Alright, so something we want to point out is this is 1 centimeter, 2 centimeters, 3 centimeters, 4 centimeters, right? So the cannula is just between 1 and 2. And something that's kind of amazing is that this is the superficial gluteal fascia, and then this is Dr. Patino's cannula, which is really right above the deep gluteal fascia. So if he withdraws, I think we'll be able to see it a little bit. So he's going to move it a little bit. And so this is the space, right? It's maybe a centimeter, I would think probably even less, and that's where he can put the fat.
That is incredible. This is the tiniest space, but you can see how if you do this procedure blindly, which has been done for many, many years, you can easily go into the muscle and inject fat into one of the inferior superior gluteal veins, and that fat graft gets sucked into the major venous circulation, returns to the heart, goes to the lung, and the patient immediately dies. So this is why it's so important to make sure that you do this procedure under ultrasound guidance, preferably by a surgeon that's certified by the World Association of Gluteal Surgeons. This organization specializes, is the only organization in the world that specializes basically in this very procedure, and I am very honored to be the CEO of the World Association of Gluteal Surgeons, founded by famous Dr. Miami, Dr. Michael Salzhauer. And so we're going to show you exactly, this is a very, very good case. I'm going to show you how I'm going to wiggle the cannula so you know where the cannula is. Look at the tip of that cannula, Nicholas. And now look at that great cloud and see how this superficial gluteal fascia and the deep gluteal fascia are going to create this space for the fat graft.
So as you said, we have this great cloud of fat entering the space, and you can already... Alright, so what we saw is doctor put a little bit of fat, a bolus of fat, into the deep subcutaneous space underneath the supragluteal fascia but above the deep gluteal fascia, and fat is pushing now, so we're going to see the deep gluteal fascia get pushed down and the superficial gluteal fascia get pushed up just a little bit as fat enters this space.
And so I'm demonstrating how I inject as I withdraw. And this is just beautiful anatomy. Now we have a lot more space, don't we?
Yeah.
What is the space now?
Well, so now deep gluteal fascia is closer to about 3 centimeters, a little bit 2.5 maybe, close to 3, and then the superficial gluteal fascia is under 1. You know, it's above here.
Yeah. So the space almost triple, or it did
Yeah,
triple,
yeah.
more than triple.
Right.
Incredible. Thank you. Wow, look at that. What color is that fat graft? Completely bloodless, oilless, beautiful fat graft. It's just incredible. Thank you.